Hello and welcome everyone. Thank you so much for joining us in today's webinar, Supporting Workers with Long COVID. My name is Elizabeth White and I am the team lead of Learning and Development with the Work Wellness Institute, and I'll be hosting and helping to moderate today's webinar. I would like to start by acknowledging that I have the privilege to live and work on the traditional, ancestral, and unceded territory of the Coast Salish peoples, Squamish, Tsleil-Waututh, and Musqueam nations. We would like to thank our academic team and our 9 founding partner organizations in the Harnessing Talent Project. Harnessing Talent, Alliance for Recruiting and Retaining Canadians with Disabilities and Mental Health Challenges, is a 3-year project funded by Employment and Social Development Canada. This webinar is made possible through the support of ESDC, as well as memberships to WWI. We thank our advisory committee and speakers who contribute to this webinar series. While we're just waiting for a few more to join and give people a chance to settle in, I'll just go over a couple of housekeeping points for this webinar. Hopefully at this point you're able to hear me as well as see our beginning of the presentation on our screen, on your screen. And audio should hopefully be coming through either your computer speakers, or if you've chosen to dial in through the conference line, you should be able to hear us through either of those mediums. In terms of your communication portal with us today, you will see in the GoToWebinar panel that there is a questions box or line, depending on how you have your panel today. And that is your communication portal, as I mentioned, with us today. So whether it's a question that you have, or it's a bit of a technical issue or a comment, or just trying to kind of come into the conversation, please use that questions box to communicate with us, and we will get back to you, particularly around technical issues, as soon as we are able to hopefully get you back up and running. As well as particularly, there will be a Q&A session held at the end of the presentation today. And so if you have questions, please again use that questions box to put them through. And please do not feel the need to wait until the very end, where we're kind of in the official Q&A time. If you have a question as you think of it, just pop it through and we'll be sure to take a look at them when we do have that time. And some following the webinar topics, just in case some of those questions might be bubbling to the surface already. Any questions we don't have time for within our allotted hour today, we'll be sure to get those answers and distributed to you through the post communications that you will receive from this presentation. And that would also include the recording of this webinar today, as well as any presentation materials associated with that. And you'll receive the appropriate links and things to view again through our website. Just a note to our members, so our organizational members of ARPA Australia, as well as individual WWI members, just a quick reminder that you will receive free certificates of attendance. And for those particularly in the organizational member category, you will need to have filled in your record ID field when you've registered, so that that certification process runs smoothly for you. So with no further ado, I'm very pleased to announce and introduce our speaker for today. We are very excited to have Dr. Karina Nielsen with us today. Karina is a full professor of work psychology and director of the Institute of Work Psychology at the University of Sheffield in the UK. Karina specializes in organizational interventions, for example, how we can foster employee health and well-being through changing the way work is organized, designed, and managed. Another area of expertise is sustainable return to work, how we can support workers with common mental health challenges and disorders stay and thrive at work after long-term sickness absence. The key to Karina's research is the IGLOo framework, which suggests that in order to develop healthy organizations, it is necessary to build resources at the individual, group, leader, and organizational levels. We're very pleased to have her speak with us today. Thank you so much for being here, Karina, and I will now pass things over to you.
Thank you very much, and it's a pleasure to be here, even if just virtually. And as was just said, please ask your questions in the chat. I'm more than happy to take questions. What I'll be talking about today is long COVID. I've been working with sustainable return to work for a number of years in relation to common mental disorders. So how can we help people stay and thrive at work once they return to work after long-term sickness absence. But in the last couple of years, we've become aware that long COVID is a huge issue. How can you help people stay and thrive at work once they return to work after? Well, in fact, they're still suffering from long COVID when they return to work. And we're using the IGLOo model to understand that. So my name is Karina Nielsen. I'm from the University of Sheffield, and I have done this work together with my colleague Joe Yarker, who is a co-director of the research-based consultancy Affinity Health at Work. She's also a reader at Birkbeck College in London. The research has been funded by the CIPD in the UK and the Sheffield University Management School. So the approach we are taking to employee well-being is that we need to look at the whole system. We need to understand the many different players that help people stay and thrive at work. We are drawing on Hopfall's conservation of resources theory. I don't know whether you're all familiar with it, but in brief terms, it's essentially that as humans, we're striving to maintain and develop resources, anything that helps us achieve our goals. And we're talking about both positive and negative spirals. So a positive gain spiral is that I grow my resources, I apply resources to gain additional resources. So we have a positive gains, positive spiral. A negative spiral is if I don't have a lot of resources, I waste my resources, and it all goes into a black hole, and I don't have the resources to maintain or get a better employee well-being. In terms of this research, we did an evidence review, we did a literature review of what's already out there on how you can support workers with long COVID in the workplace. We conducted interviews with 14 workers who were self-reported to suffer from long COVID. Many of them had fallen ill in March 2020. It's not even a year ago now, it's almost 2 years ago. And therefore, they're not necessarily diagnosed with long COVID because there was no such awareness and definition of or diagnosis of long COVID at the time. They all are treated for long COVID now, or were at the time of the interview. We also conducted roundtable discussions with 43 professionals, occupational health professionals, human resource managers, line managers, senior managers, to get their perspectives of how they support employees with long COVID staying and thriving at work after long-term sickness absence. So, as also mentioned, we are focusing on the IGLOo level. So what we are saying is that there are resources at the individual level, within the individual, at the group level, the work group level, colleagues, leader, line manager, and the organizational level, occupational health, human resources, senior management. There are resources at all these levels that can help people stay and thrive at work. There are, of course, also barriers, so we are looking at that as well. But the central premise of our research is that you cannot help people stay and thrive at work on your own. It has to be multiple levels working together to create a good environment for people with long COVID. So what is long COVID? I'm relying here on the definition of the National Institute of Health here in the UK, and they define long COVID as a sign and symptoms that develop during or following an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by an alternative diagnosis. So 12 weeks is the key here. In terms of prevalence, there's research in the UK that shows that 1 in 5 people that have had COVID-19 experience symptoms lasting between 5 to 12 weeks, and 1 in 10 people will suffer from long COVID, i.e. have symptoms after 12 weeks or longer. It's estimated that about 1.9% of the UK population are experiencing long COVID as of October 2021. In terms of the symptoms of long COVID, this is just some of them. There's a paper out by Davis et al. From 2001 that lists more than 100 symptoms, but some of the most common symptoms are these. And in our sample, I think we found that all 14 workers experienced fatigue, breathlessness, brain fog, and poor concentration, and then a range of the rest of the symptoms that are listed here. So in terms of how our participants or employees describe long COVID, it's really some strong messages coming across here. One described it as, it's not natural to feel like your arms and legs and head are being ripped off, like those pictures where they show people being pulled between two horses. Quite a few of our participants reported the long COVID and the long COVID journey as a roller coaster. So one day you can be fine, the next day you're feeling really poorly. So it's not as if they get better week by week. They get better and then they get worse. Some weeks they're better than others. And it's taken them quite a long time to realize what it was that was going on with them. Quite a few of them didn't have very severe COVID-19 symptoms. They perhaps have a bit of a cold. Some of them didn't even realize they had COVID-19 until they were tested positive. So it could last 1 or 2 weeks before long COVID really hit them. And it could take some time to realize, actually, I'm not going to get better. I'm not recovering. So I need to think differently about myself and how I deal with the symptoms now. Another of our participants said, well, the physical side, I'm recovered to a stage where I can do my job physically, but cognitively, the brain fog just hits them so hard. So she said, there's no way I could take responsibility for somebody else's healthcare at the moment. A lot of our participants were in healthcare, by the way, and of course, they were some of the hardest hit because they have such an exposure to COVID-19. Moving on to the individual level, what are the resources and barriers to staying and thriving at work? So the resources are an acknowledgement within yourself that you have reduced work functioning. There are so many things you can't do now in your job that you were able to do before. You can't just push through like you are used to. It's also resetting career expectations. So maybe not going for that promotion that you had hoped for, changing jobs, because you're simply not in a place where you can do the job. And many of them are basically hanging in there by the thread of their teeth. It's also being open and communicating about your work functioning. So what can you do? And that was really hard for many of them, because many of them said, you know, we're used to working hard, we're used to performing, and all of a sudden we have to realize that we can't do that, and we also have to communicate to our line managers that there's only so much we can do. We need work adjustments. In terms of the barriers, because it's such a new phenomenon, it's difficult for the individual to know, what do I need? What work adjustments do I need? How do I get a diagnosis? Who do I go to? Who can give me that diagnosis? And of course, it's not even it's hardly a diagnosis, and it certainly wasn't in the beginning of 2020. There are also barriers in terms of participants not prioritizing self-care, and also barriers in terms of it's really hard for them to accept this is a slow pace of recovery, leading back to the roller coaster journey. There are also those that call it a COVID coaster, because you get better, you get worse, 2 steps forward and 1 step back. So really, it's really difficult to accept that it is a really slow journey. Some of the comments that we got, or some of the things that they told us, was that I've never had time off other than 1 or 2 days with the odd something ever since I've been working. So it's really unusual to be ill. So I've actually had 2 weeks off at the beginning, which was really unusual, and I feel incredibly guilty being off work. Another one said, I think it's been better for me to have some contact with work than none at all, because doing what I'm doing at the moment prevents the isolation from being off. And as I said, many of them work in healthcare, and they felt guilty, they felt isolated because they weren't able to work at a very, very crucial time in the healthcare system, with the healthcare system being under so much pressure. So it really hit them double, being off work, but also not being part of the community, not being able to contribute. Another participant said, it's been absolutely crucial to be able to say all of those things, so being open about the reduced work functioning. So I've had more honest and open conversation with my manager, which has helped in terms of putting the plan or making a plan for what's going to work. For me, things that haven't worked on my journey are when things have been almost imposed on me. So it's when it's been manager-led rather than led by me. So it's the recognition of what are the symptoms that I'm suffering from and what kind of job can I do in order to function at work. At the group level, some of the resources that were mentioned to us were instrumental support, helping in or stepping in to help with tasks. It's also emotional support and understanding, and proactive approach to managing team well-being. So how do we make sure that everybody functions well in this team under the pressure that we are under? The barriers are the lack of knowledge and understanding from colleagues. So one of our participants described the toxic positivity, the lack of understanding from colleagues. I found a lot of toxic positivity from work. So it would be masked as like, oh my God, are you still unwell? We definitely think you should be at work by now. So those kind of little sniping comments. Another comment was, I didn't feel like I was particularly confident in my decision making either. And we make decisions on whether patients are admitted to hospital or not, or we prescribe. So it's basically the brain fog, the lack of concentration, make returning employees doubt their own ability to make good decisions. So this participant described how she would go and check with a colleague. So have I made the right decision with regards to this patient? Just running it through with them and then saying, okay, is this the right decision? And that helped build her confidence. So she felt better making the decisions, and decisions that are crucial to somebody else's health and well-being. At the line manager level, there are a lot of resources extending the phased return period to 6 months or even more. Quite often in the UK, the normal phased return period is 1 month, and then you're kind of expected just to be able to work full time. But because this is such a roller coaster journey, there've been a lot of discussions and needs around it needs to be a very extended phased return period. It's also crucial to adjust tasks. So, for example, removing cognitively challenging tasks, physically challenging tasks, depending on the symptoms of the individual. Really important to make lots of work adjustments. It's also being flexible in terms of providing opportunities from working from home, being in an environment that tires you, is being around colleagues, being around patients, being about clients, children, if you're working in a school, so working from home, but also reducing or taking away the commute, so you can work from home and you can take breaks. So for example, we saw examples of you can perhaps work for half an hour and then you need half an hour off, and it's better that you do what you can rather than saying I can't be at work at all. It's also providing opportunities to work flexible hours. So several of our participants would start at 10 at 11 rather than 9 o'clock, because it gave them the opportunity to kind of wake up, if you can call it that. And also maybe taking a day off when needed, when you're feeling poorly, rather than going on sick leave. What was really important at the line manager level is to take an individualized approach. So having that dialogue with the individual worker that has returned, and say, so what do you need? And also flexing work adjustments. So now we try this, does this work? If it doesn't, then we'll do something else. So really the flexibility, adjusting for workers who have returned, but also as they get better, they get a bit more, but also when they have a drawback, they feel worse, taking some tasks off them again and doing things differently. As with the work group level, lack of understanding was a major barrier, not understanding that you just can't return to work and perform from day one. And also line managers were impatient in the slow and fluctuating capacity of the returned workers. really important to understand this isn't just something that you recover from within a month or 2 months. You might be fine for 2 months, and then there might be 3 months when you're not functioning properly. So what we saw, because many of these worked in healthcare, as I said, some also in schools, is that their role would change completely. So for example, here's one example. Non-clinical work would normally make up 20% of my work role. So my normal split would be 80% patients and 20% non-clinical. Whereas now it's 100% of what I'm doing, the non-clinical work. So I'm doing the things that I can do in my own time. So basically, rather than being in and facing patients, she would now work from home and she would do purely administrative work. And that was the work she could do. And she was happy doing that work because she wanted to make a contribution. She didn't want to be isolated. And this was the kind of work that she could do. So we saw that a lot. Of course, it's very simple to say that because there are jobs where it's simply not possible to do that. For example, we had a returned worker who worked in a general practice, and she couldn't just do 100% administrative work. She needed to see patients. So this is an ideal work where that flexibility is important and possible, whereas there are other occupations where it's simply not possible. But another one put it like this, saying about the line managers, they need to create a space where you feel that it's welcome that you do that, that you deliver what you can and that you work as you can. And that also they understand that you don't know for sure, like you can try and make, and that's the hardest thing, is that you know you can try and promise a deliverable and an output, but at this point in time, forecasting the future and what you can do is all of your self-knowledge from before. It's not necessarily you're going to get a hold and stand up to what you thought. How long will something take? So basically what she's saying is that you simply don't know how you'll feel tomorrow. So even if you promise to do something, you might not be able to deliver on it because you have a setback, and there's just nothing you can do about that. And your line manager has to acknowledge that as well. That is not something predictable. This recovery isn't predictable. So there just has to be an understanding of you might not be able to deliver when you said you would, or when you were set a deadline. It has to be flexible. At the organizational level, the resources that should be in place are providing flexible working practices and leave policies. So allowing the line manager, enabling the line manager to make the work adjustments that are needed in order for the returned worker to function. It's also establishing a culture of psychological safety where mental health and physical health are prioritized. So people feeling safe that it's okay for me to not be okay, and also be able to work to their best ability. Reviewing absence management policies to avoid punitive systems for fluctuating conditions. I don't know what it's like in your respective countries, but in the UK, especially some public sector organizations have got some really punitive systems in place. Like, for example, if you are on sick leave 3 times in 1 year, then you go on a capability and you might get fired if you have any subsequent sickness absence. And because people they return to work, they go off sick again, they return, they go off sick, that really doesn't work here because it doesn't allow them to recover at their own pace. We had quite a few of our participants that had gone on sick leave in March 2020, and some of them had been on sick leave, long-term sick leave, 3 or 4 times between March 2020 and at the time of interviews in July, August 2021. So really important that the HR policies are adjusted to allow for the fluctuations in health of long COVID employees. The barriers at the organizational level was lack of access to occupational health because it wasn't a recognized a disease, and then they couldn't get access to occupational health. And what we also saw that human resources would prioritize policies around return to work and hybrid working, and therefore didn't pay as much attention and as they could and should have done to employees with long COVID. A couple of quotes about the organizational level. So human resources sort of put you through the phased return. You're meant to try and hit certain goals at certain weeks, but that didn't work. The recommendation isn't for long COVID, I don't think, and they quickly became aware of that. Another one describes the many different symptoms, the difficulties of occupational health managing those symptoms. It's a tick box exercise. We've done occupational health and physical disabilities. Yes, we can give you computer equipment, we can do this, we can do that, we can. But for the invisible things like fatigue, brain fog, depression, mental health, mental illness, there doesn't seem to be much accommodation for that type of thing. And if you recall what I said, those were the most common symptoms that all our participants reported. It was the brain fog, it was the fatigue, it's not being able to function cognitively. What we also found that at this level was that some of the larger, especially healthcare organizations, created support groups for people with long COVID. And one of our participants said, all of us have a struggle to go back to work, which I think why we're also part of this advocacy group. So I've got people who are going through a similar journey to mine. That has helped. So the social support, the emotional support in it. But I've also got people to say, how about doing it this way? How about asking for this? So it's sensible advice for people in the know, and that's also been helpful. So the peer support has been hugely useful. So actually also getting good advice on what are the right or good work adjustments. How can we actually enable people to stay at work? So at the last level of the IGLOo model, we've got what can be done outside the organization. And some of the things that have come up here is the healthcare system. There's need to a timely access to integrated care. So by now in the UK, there are these long COVID centres where you can get treatment, whereas in the beginning there was nothing in the healthcare system that offered anything for long COVID patients. Our participants also called for government policies and information, trusted sources of information. We don't have to go into a discussion about the miscommunication, misinformation about COVID-19 here, but it's really important that there's information at the government level about what is long COVID, how can organizations manage long COVID, and what are the government policies in place for that. At the moment, not so many. And they also emphasized it's important that there's an understanding in media, there's awareness about long COVID, how many people are suffering from long COVID, what are the symptoms, how can it be managed? And again, there's not so much in the media on that. Unions were also reported to play an important role in order to advocate and provide advice on how to manage long COVID. And like in the workplace, also support groups with outside the organization. Some of the quotes here is, I think it's really important that there are government policies that are put in place to support people, because there's a huge amount of the workforce that are struggling at the moment. I think the extended phased return is a good example of the need to have something like this. Another one said, people still, even to this day, don't have any understanding of what it's like. And you can't really expect them to, but they very much think it's a condition you die from, or you will survive, talking about COVID-19. And I think it's the media's portrayal of it echoes that. And the government's exactly the same. I mean, they never talked about long COVID. So people think, yeah, you either survive or you're dead. So basically what I've been trying to say here is that we need to have a joined up approach, a whole systems approach to managing workers who have returned or who are returning to work after long COVID sickness absence. Everybody has a role to play. Returning individuals themselves, they have to realize, what is my current level of work functioning? How can I contribute in a good way? It's also work groups need to be understanding of the individuals and the fluctuations in their health. and offer them the support they need, both emotional support but also practical instrumental support. Line managers play an absolute key role in supporting returning workers, making adjustments, being understanding, and also, again, understanding the fluctuations. And I think really the key here is fluctuation in the health and the work functioning of returning individuals. And also organizational professionals, they play a key role, putting the policies in place, providing access to occupational health, and occupational health being trained in how to provide the necessary support. And I think that's really key here. We all have a joint responsibility, but also we need to increase the knowledge, skills, and confidence in how to support workers. What we saw in the roundtable discussions with the occupational health professionals and human resources was that when these things kicked up at the beginning, they had no idea what the symptoms were, what people were suffering from, how to support them. So training and awareness creation at all levels is really important to help workers return and stay at work, managing the long-term condition that long COVID may be. It's still so new, so we don't know whether people recover fully. There are some indications that's not the case. So long COVID is probably here to stay, and it's probably here to stay in the long term for individuals. And what we are calling for is also, we need more research to help us understand how to support workers. We did a literature review, and we didn't find any studies that focused explicitly on how to support workers with long COVID in the workplace. We find snippets every now and again, here and there, about the role of the unions and line managers need to be supported, but we didn't really find any in-depth information or research about how to manage long COVID in the workplace. It's all about symptoms and managing the symptoms. So that was all I had to say for today. So if you have any questions, do ask them now, but also feel free to get in touch either with myself or Joe Jakob.
Well, thank you so much, Karina, for this conversation and bringing forward all of these different levels and layers that we need to be thinking about in something that, you know, as you mentioned, is fairly new. So wanting to bring attention to that. So we will go through the question and answer period now. We have lots of time to have that space together. So I'll just start things off here with our first question. I recently read about emerging situations where individuals are experiencing symptoms of long COVID, but can't confirm that they actually ever had COVID as an original diagnosis to begin with because of lack of testing availability or minor symptoms experienced. And so maybe a test wasn't administered, that kind of thing. So could this be quite a difficult scenario for employers and employees to navigate, and kind of any insights there?
Yeah, absolutely. And we see that because many of our participants in the interview study had gotten COVID in March 2020, April 2020, and nobody knew what long COVID was. A lot of them worked in healthcare, and there was no testing facilities at the time. So they have kind of been diagnosed with long COVID retrospectively, saying it fits the very diffuse symptom picture that we find for long COVID, but we don't actually know whether you ever had COVID. And that has been a struggle for many, trying to convince the healthcare system that this is a real problem. Long COVID does exist. Convincing human resources, line managers, senior managers, that has been a real struggle very early on. As I said, many of our participants were in healthcare, and I think many healthcare trusts have now woken up to the fact that long COVID is a thing. And of course, with testing, it has also become easier to make the argument, I tested positive, and now 3-6 months down the line, I am struggling from these symptoms. It is most likely due to the initial infection with COVID-19, but absolutely huge problem from what we saw in our study.
Is there anything in particular that employers can do to help support in that if the employees is kind of having a difficulty in getting that initial understanding of where this came from, or just kind of continue through those kind of layers that we've talked about today?
Yeah, I think what you can do is at the government level to create awareness about this, creating policies, supporting policies, translating that into organizational policies. And I think that at the national level, there's a huge responsibility to create awareness about long COVID and acceptability of long COVID and how difficult it is to live with long COVID. We had some.
Speaking. Oh,
Yeah.
sorry.
No, I didn't bring it in here, but there were some really gruesome examples of people saying they were so poorly they couldn't even sit up to eat a meal when they were at their worst. And I mean, that kind of brings into perspective how difficult it is to return to work and stay at work for these people, and how quickly you can have a relapse into something very, very serious.
Absolutely, it's a tough one when, as you've mentioned, it's kind of this roller coaster without a map, so to speak, of knowing where that turn is, where that loop might be.
Yeah.
So moving forward in our questions, is long COVID a presumptive diagnosis, or does a physician have to identify it in that 12 or more weeks when symptoms are still present?
Sorry, I didn't hear the first part of the question.
So I think from my understanding of the question, is long COVID a presumptive diagnosis, or does a physician need to actually identify it? So kind of versus this presumption versus actual diagnosis kind of question.
That's a question, I'll be honest, and I can't answer because I think it's still so fussy. I don't think there are even any guidelines for GPs, general practitioners now, of how it should be diagnosed. So it's not a question I dare attempt an answer to. I'm sorry.
Okay, but no, fair enough. So the next one is, feels like we are fighting an uphill battle, especially as restrictions are being lifted around the world. What can we do in the meantime to further support people in returning to work? And so it's a bit of a part 2 question here. So meantime, to support people in returning to work, as well as, are there any particular resources that you might recommend accessing to provide to employers or the human resources professional in that line of supporting return to work?
Yeah, so as I said, this research has been partly funded by the CIPD in the UK, and we have in fact written some guidelines and a report for them that should be available quite soon. So at least that's one source. The Society of Occupational Medicine in the UK has also developed some guidelines. I'll be perfectly honest, I don't know how great the uptake is in organizations at the moment, but I mean, I don't know how many of you are from the UK and know about the lifting of restrictions, but I think it's a huge concern that now there's kind of attitude that we're lifting the restrictions. It doesn't matter whether people get ill because they are vaccinated, and it won't be that bad. The Omicron isn't too bad. But I think the dark horse in this game is the long COVID, because that hits hard, and it's not something that you recover from in 6 weeks. So I think that's my personal worry, is that long COVID is going to have such a huge impact on people's lives, on the healthcare system, on the economy in the longer term, because you're not taking it, or the government isn't taking it seriously, and organizations might not be taking it seriously either.
It's just to build on that, as you said, there are these external factors that help or that kind of need to be a part of the conversation, and as one of those levels, you know, in that, as you've mentioned, perhaps there might be a lack of that kind of support, but for those organizations and, you know, line managers and human resource professionals that are trying to kind of move that needle forward, is there any advice or recommendations you can perhaps provide on how to kind of keep going on this uphill battle when maybe there is a lack of support elsewhere that could help them?
It's a really difficult question, but from what I can understand from what's going on in the UK at the moment is that healthcare organisations have been forced to do something about it because they've got so many workers that suffer from long COVID. And that's a huge motivator, that if you have a lot of people on sick leave due to long COVID, you need to find ways of helping them back to work and creating jobs for them that enable them to work. It's a bit cynical, but I think it has helped when you realize that a relatively large proportion of your workforce isn't able to come to work. And of course, in the UK, healthcare is severely understaffed. So that's a rather cynical motivation that you need to make the most of what you have. So I think that's that's probably my answer to that. But I think there's I don't want to portray line managers as the crooks in this, but they of course have performance targets. It's difficult to have an employee that doesn't perform 100%. But what we have also heard from the interviews is that line managers are understanding, and they say, I'd rather have you as much as I can than not at all, because we are so short-staffed.
Yeah, that's one of the difficult balances that another question has brought forward as well, in this need for kind of potentially different type of work maybe that was done, and the flexibility in deadlines and all of those things, where the flip side of that is there still is perhaps an organizational need for deadlines to happen and work to be completed. So was there anything there to add around that, of helping to balance that really between organizational and individual needs?
Yeah, and I think what we've heard in our participants is that many of them were now working, doing tasks that they wouldn't have even considered 12 months ago, but now any kind of job that gives them some kind of connection to the workplace, some kind of meaningfulness, they feel they make some kind of contribution is better than no work at all. And I think that's really key, and it can't be done in all organizations, but really considering, is there something we can give this worker that enables them to work at the present time to the ability that they have. And what we found also was that many of our return workers said, you know, I went back too fast, I did too much too early, and I crashed way too hard. Or way too quickly, and line managers play a key role in not putting that pressure onto their employees. And of course, it's hard when you have performance targets or these kind of things, or you're just impatient, or you don't understand what is this thing called long COVID. And I think, again, coming back to, I think that's where organizations, governments have a responsibility, but organizations, human resources also have a responsibility to provide training for line managers, and how can they make adjustments, increase their awareness of what is long COVID, and promote the understanding at the group level and the line manager level of this is, we want people to be at work, and you need to have an understanding of what are the problems that long COVID employees are experiencing.
No, those are a couple of points that stood out to me in what you just mentioned around kind of coming in too fast and then needing to kind of completely perhaps go off again, versus if there was that flexibility and thinking through things a little bit differently. You know, it's a little bit of partial is probably best for both sides than none. As you mentioned, you know, that lack of isolation and things if you're still there in some capacity. So something to think about for sure. Yeah. So flipping gears a little bit into a bit more of around kind of long COVID and perhaps some factors around that. So we have two questions around this. So is comorbidity a factor or predictor of long COVID? And then I'll let you answer and go to the second.
Yeah, I'll be honest, I have mostly focused on how can we help people in the workplace, because I'm an occupational psychologist. the risk factors that have been identified are working in healthcare, being female, being between 35 and 55. But in terms of comorbidities, I haven't seen an awful lot. A lot of what, I mean, all of our sample, and of course it's only 14, so, you know, in epidemiological terms, it means absolutely nothing. But none of our participants had any. They were all super healthy, super physically fit, hadn't had any previous problems. So as far as I'm aware, and please don't shoot me if I'm wrong, I'm not aware that there are huge issues with the comorbidity in terms of getting long COVID.
And this may have the same answer, but I'll just ask it in case there's some nuance as well around, are there any trends at this moment that you've seen or are aware of within your research and colleague research around pre-existing conditions having a tendency to cause or again be a predictor of long COVID?
No. Yeah, unfortunately not. And I think there is some initial research saying that being vaccinated also helps against or protects against long COVID.
Okay, great, thank you. And then I'm just looking through our questions here. So what directions are you expecting research to go in? Is it kind of on the physical side of things of long COVID, perhaps the mental health components? Just kind of your thoughts on what you're kind of expecting the future of this type of research will go to gain more information all around.
Yeah, I think, I mean, this is so new, and to some extent I'm looking into the crystal ball here, but I think there's a quicker awareness about how you can treat the physical symptoms of this. A lot of participants and also generally people with long COVID, they have problems with heart rate, increased heart rate. It just completely explodes and gallops away, and they're trying very hard to treat that symptom, whereas the more mental health issues of it, anxiety and depression, there's also a discussion whether that's a side effect of long COVID or whether it's part of the long COVID diagnosis, but that's another discussion. But I think, like with common mental disorders, it takes longer to develop an understanding of how can you help workers with that. So my feeling is, and what I've seen so far, is that there's a greater focus on the physical, managing the physical symptoms than the more cognitive and mental health symptoms.
Okay, I know it's a bit of a crystal ball time, and so we'll see where we go, right? We've all been kind of watching that crystal ball these last 2 years. So kind of going back to this relationship between manager and individual, what are some things managers can do to ensure that the kind of bulk of the onus or responsibility doesn't fall on the individual when returning to work?
It's having that conversation. It's having the conversation. How do you feel? What do you need? It's checking in ongoing on the returned worker just to make sure that they aren't working themselves into that dark place again because they want to perform. It's being flexible, checking in all the time or continually saying, so do the work adjustments that we made for you, do they work? Can you take on a bit more work? Should we take some work on you? Should we do things differently? Do you need to work from home? It is, I think the really important thing is checking in and taking into consideration those fluctuations, because what we found across the board is that the health just fluctuated so much. The symptoms fluctuate so much even from hour to hour. So I think that's really, really crucial. It's checking in on employees and having a temperature check on where are they now. And also, it's important that it's not something that they can manage on their own. They need the line manager's support in making those work adjustments, depending on the level of autonomy you have in your job.
Yes, that communication and thinking outside the box and all of these things to really, as you mentioned previously, an individual approach and those kinds of things. We may need to ask for a bit of clarification from the person who put this question in, but maybe you are aware of this acronym. But would you recommend MTBI approach to return to work? As an example, pacing strategies, psychological support, etc. Mild traumatic brain injury support approach. That was what that acronym was for.
I don't know it in detail, but I would say any kind of support is probably welcome at this stage where there's so little knowledge about what works.
Right. Just as I know, because you had mentioned perhaps maybe discussing the nuances there, as you had said, this kind of standardized potentially approach that people had used previously was not quite working for those with long COVID. So are there some nuances that human resources professionals or the managers can think about that might be helpful here, as opposed to perhaps that usual kind of paced return to work that we're all perhaps familiar with?
Yeah, so I think the most important thing, and again, I'm talking from a UK perspective, as I said, the 1 month phased return is kind of, the idea is that you return to work, you have a lighter load, you gradually take on some more tasks, and then you work yourself up to full capacity. But the problem is here, 1 week you can be full capacity, and the next week you can be at 10% capacity. So it really is changing the policies so they allow for that flexibility. And I think many of our participants found it useful to work from home because they were kind of in a confined space. There wasn't noise around them, hopefully not with not too many children around them. And they weren't stressed out by all the sensory inputs that they would get from the workplace. But also, if they needed to, they can go and have a lie down. So I think flexible working from home policies, and many of them said, what has saved me in the first months was basically that we had to work from home, so we couldn't get into work, and that had helped them recover. But then they're supposed to return to the workplace, and that's where things go wrong, because they're not ready to be hit by all these impressions that they get at work. So flexibility, I think, is key at all levels, and an individualized approach, because the symptoms differ so much. So one person needs one thing and another person needs something else. So and there tend to be in HR policies. Let's see what the HR practitioners think about this. There tends to be a rule book, a standardized protocol for how you go about bringing people to work. That just doesn't work with employees with long COVID.
So it sounds a little bit like kind of perhaps throw away the rule book, so to speak, and really kind of just perhaps maybe starting from scratch, or just trying to, that old kind of saying of fitting a square peg into a round hole might not be the best approach here, to really, as you said, just go from the individual, case by case, day by day kind of approach. Absolutely.
And I think that, as I said, the flexibility is absolutely key here, but it is also training, because I mean, this is a new situation for everybody, and you can't necessarily expect HR professionals, occupational health professionals, to know what to do. But what we heard from participants was that what really worked was listening to what their needs are, rather than assuming and presuming that they knew what was needed. And there are some gruesome examples of the lack of support that was experienced, like, for example, occupational health saying, oh, are you suicidal? Oh, you're not suicidal, then you're not entitled to mental health support, or you're not entitled to any kind of support with your cognitive problems. And of course, that's the complete wrong way of going about it, because if you say you've got mental health problems, you do suffer from depression and anxiety. Doesn't matter whether you're suicidal or not, you still need support with your mental health problem.
And that speaks, again, I think, to what you were saying around the organizational and policies, and kind of needing some review on those as well, to perhaps open that scope and ensure there is those supports perhaps wider than previously needed or thought of.
Yeah, And I mean, ours is such a small research project, and I think we really need a lot more research in how can we best support organizations, and then we can start providing the training and recommendations for policies and that kind of thing. But at the moment, there's still so little research in this area, so it's really difficult to give a lot of informed recommendations and guidelines for how to do this.
Right. We have a question here just around kind of the different symptoms that we've talked about, perhaps we're aware of and know of around long COVID, and thinking about the things like fatigue and perhaps neurological implications, all of these things, and actually posing the question, will this allow a person to return to work kind of full stop?
Well, we do. That's a really difficult one. Yes, I mean, some of them were working 1 hour a week, and I think it comes back to we don't want to lose these people because they are needed at work. We need people to make a contribution to society. We don't want to lose people. We also, for their own sake, we don't want them to feel isolated. Many of them said one of the key things was just doing a bit of work is better than no work, because I mean, they had so many symptoms, they were so poorly, and they were just sat at home during the periods where they were sat at home. It didn't make them feel any better because they were just, all they could do was sit and think about all the things that were wrong with them, whereas actually work gave them some kind of sense of community. It gave them something to do. Even if they can't do what they could do before, they can still feel that they make a contribution, that they are part of something greater. And I think I didn't hear any of ours that said, oh, I don't want to work, or I would be better off not working. They all said, I am better off working, but contributing the tiny little bit that I can contribute with. And some, of course, I mean, there are great variations in how much they could contribute, but there really were some that worked 1 hour a week, and that was what they could do.
Right. Well, thank you so much. I'm just noticing the time that we're at, kind of just a couple minutes left together, and we just want to do a couple of reminders. So I want to say a huge thank you to both our audience as well as yourself, Karina, for a really great engaged question and answer period. Lots of great questions and thoughtful answers from you. So again, just thank you to both sides for the engagement and discussion today. So just before we close our presentation, like I mentioned, I just want to take a couple of minutes of reminders and housekeeping to wrap up today. So as mentioned previously, this presentation has been recorded and will be posted both on our website as well as within our WWIE campus. And all of these links will be sent to our registrants and attendees today post the webinar, post today's webinar, as well as all of the presentation slides or anything associated with this presentation. In regards to certificates of attendance for perhaps professional development needs, our organizational members of ARPA Australia, as well as our individual WWI members, will receive a free certificate of attendance. So if that sounds something of intrigue to you to ensure your kind of free certificates from us, please go to our website at workwellnessinstitute.org and look at the Join Us section to learn more about our membership and all of the great benefits that go along with that. As without that membership, there is an administrative fee to gain that certificate of attendance. Immediately following this webinar session, you will be directed to our evaluation survey, and we greatly appreciate everyone taking that moment of your time to answer our questions, as we really do use that information to help inform our webinars and other resources to ensure that the topics and areas we're covering are relevant and timely for our audience. Our webinars are created for public access and supported by both our memberships and funding sponsors. And as well, I would love to encourage your continuation with us in our webinar series. And if you click to our upcoming webinars under our Learn and Connect section of our website, that's where you'll receive all of the information you need for our webinar program. And I'll just pay a little attention to our next webinar coming up on February 15th, Impact of Language Barriers on Return to Work. So once again, thank you to everyone for attending and being so engaged in this conversation today. And we look forward to seeing you again in our future webinars and other educational resources. And once again, Karina, thank you so much for sharing your expertise and being so willing to have this conversation and discussion with us today.
Thank you very much for having me.
Wonderful. We've hit right the top of the hour, so I will be now closing the session. And thank you once again for spending this time with us. All the best, everyone.